it's Dr. Daniel Ladizinsky. He is going to present SUTUREGARD. Daniel has been in practice for about 30 years in plastic and reconstructive surgery. He is board certified in hand surgery and plastic surgery, and then 25 years in the medical device industry with prior startup experience. Currently, he is CEO of SUTUREGARD. Daniel, the stage is yours.
Thanks, Uli. I think you really stated eloquently the physician's journey from, through the stages. It's almost like the stages of grieving in a way that, you go through this, you plant your flag up on the mountain, and then you realize all you're worried about is getting up and down the mountain safely and getting the patient back in one piece. And then, it's just it's more relief than exhilaration as you go through decades of practice. But I think we accumulate all this knowledge, from scar tissue from our failures and those that we share. And really, that's kind of my story here. I saw a slide that you put up. I was with Kaiser for quite a while too. Robbie Pearl put up this slide once that said, United States is number 1 in percent GDP spent on healthcare and number 32 in outcomes. And that really upset me a lot. That was years ago. I hope we've moved up a little bit in outcomes, but that's been a driver for me, is to take the knowledge that, I accumulated. As a plastic surgeon, I would see everybody's failures, including my own, in the hospital. And, you get to see the patterns of unmet needs and what fails. And sutures fail us when they're under high tension or when tissue quality is poor. Sutures have been around for 5,000 years. So it was time to do something a little bit better to address this, especially with aging patients with poor tissue quality. And we've come up with SUTUREGARD. So I'm again, plastic surgeon. My co-founder is a Mohs dermatologist. We have about 50 years of wound closure experience, and this is our journey. So what we've done is developed really the first load transferring skin anchor. And that's what we describe it as when we're talking to orthopedists. It anchors a suture on the skin and transfers the suture load over a broad surface area, because standard closures fail fairly often. And I think the impact of it is very dramatic, that the leading cause of chronic wounds in the United States are failed surgeries that dehiss or open up postoperatively. And that's to the tune of $13 billion. And again, Uli pointed out, this outcome issue and the expenditure that continues to rise. And we have to do something to nail this down. We think that if you address all the surgeries that are potentially at risk for wound dehiscence, we're talking about lower extremity, because it's the most distal structure on the human body, farthest from the heart, especially below the knee. A great deal of surgery is done below the knee, and it's fraught with problems. So we focus a lot on below knee surgery. There's bad arterial inflow, bad venous return. It doesn't get elevated well. It's a lot of edema, and there's also range of motion issues down there. So it's really tough area. And also elderly patients, obese, diabetic. If you aggregate all these patients, it adds up to about 17 million procedures a year that are potentially at higher risk for wound complications. We have competitors in our landscape, and they're trying to do some other device-based approaches to bridge this gap, but they are kind of fraught with their own intrinsic problems. And one of the issues is tension. I mean, we are trying to mitigate suture tension and offset it with some other type of device. And our competition hasn't addressed this in quite the same way that we have. And they really have not solved dehiscence in the same way. You might have heard of zipper type dressings that use a zip notch type of technology. They do replace staples, but don't treat dehiscence. Negative pressure wound therapy also has not addressed dehiscence successfully. So this is our device, HemiGuard. It's an adhesive device that's applied on the skin. And what is interesting here is the stress pattern. This is a finite element analysis that we use in our engineering design process. And this is a typical suture footprint when it's placed on the skin and tied tightly. It creates a heavy footprint, which is depicted in red here. Red is high pressure. and that's a 25 Newton load, and it can impact the blood flow to the skin as well as potentially tear the skin. A HemiGuard imprint is completely different, even at a 25 Newton load. It's really a load transferring skin anchor that acts kind of like a snowshoe and spreads the tension over its entire structure. So instead of getting a concentrated focal tension on the skin, you get an alleviation of that effect. It's very simple for the surgeon to use. And some of the remarkable benefits are, number one, skin blood flow is much better because of, and this is kind of a dramatic illustration from a peer-reviewed publication. This is a leg wound. For the study, we put a single suture across the leg wound. One side has load transfer with HemiGuard, one side does not. In this imagery, red is more blood flow and blue is less. On the side with load transfer, we have better skin blood flow. And anyone familiar with wound healing knows that skin blood flow is the coin of the realm, and that's what determines healing outcomes. So the combination of better blood flow and less skin tearing has led to dramatically better outcomes. We now have 3 clinical trials showing 80% reduction in wound dehiscence, both in skin cancer excision wounds, diabetic amputations, which is a really severe at-risk group, and also open reduction and fixation of internal of fractures of the ankle. This is a brief video illustrating how HemiGuard prevents sutures from tearing through the skin. And what the load transfer is doing is bringing the tissue edges gently together without causing trauma, because that suture force is dispersed over the entire structure. It's very easy for surgeons to use it. They don't have to change their suturing technique. In fact, we sell this with Zoom meetings with surgeons, and that's our training module. It's just an online brief meeting, and we explain them how to correctly apply and adhere, suture through it, and complete their closure. I'm going to show this is also a clinical view. This is an actual wound, so I apologize if anybody's put off by that.
Tight shin wound that has some fairly fragile skin surrounding it. So first, I'll lay down the HemiGuard strip on each side. So there's 2 backing portions. First, I'll take the backing portion off the rigid portion, put that closest to the wound, peel the backing strip off the remaining portion, and adhere that. I'll press down on the adhesive to make sure it's got good contact. Then I'll use a retention suture through the holes to provide the tension to close the wound. I like to have somebody blotting while I'm doing a lot of these steps. You'll notice to keep the area dry. I'll have somebody pinch it here often, or I could just hand tie it, and that has approximated the wound and is bearing the load of the closure. I'll then start my layered closure. I'll do some buried suture. This is absorbable polygalactin suture that I'll place here, and this is just interrupted buried sutures. And so I'll place a few of these in the wound just to support the wound closure for when the HemiGuard is removed. And so here you can see me tying it under very minimal tension because the HemiGuard is taking a vast majority of the tension, and it's cut. In this case, I finished my deep layers, and then I'm putting in some top sutures. This is just 4-0 nylon. And then for these leg wounds, I like to use some glue between the sutures, and this will just seal those epidermal edges. And it has multiple purposes. It's antimicrobial. It'll seal the wound so there's not a lot of exudate and to provide some wound strength, but it will also seal the wound so that there's not as much exudate to get the HemiGuard wet. You have to keep the HemiGuard dry. So we'll often apply a dry dressing at this point and tell the patient to keep the wound dry for at least 5 days post-op, and here also to limit activity. And we'll remove the HemiGuard in 7 to 10 days and top sutures either in 2 weeks or 3 weeks. And here's the finished wound. This is a video showing.
We are, it's easy to use, and this is how we train our surgeons with simple videos like this. We are registered, we're on the market. We've been on the market for almost 2 years, and we're really starting to get traction. We have all kinds of case use. Our most dramatic outcomes have been with diabetic amputations, which, as you may know, are kind of a pandemic within the pandemic. As a lot of diabetics were not getting their health maintenance care and coming in for foot checks. So the rate of amputations went up dramatically because they were coming in with emergency problems. In that setting, we've reduced wound dehiscence outcomes by over 80% and reduced the risk of below or above knee amputation by over 80%. So it's been very dramatic there. The other is fracture management. Where when you have this extra layer of support, patients can begin immediate range of motion post-op, and we're getting better outcomes with our orthopedic procedures. There's also applicability in plastic and reconstructive surgery. These are skin tumors that normally would have to be closed in the operating room. This is kind of a big wound that was closed in the office under local anesthesia. People having hand wounds are closed. They can allow them to have range of motion and not have to be casted or splinted. This very thin elderly skin type is very difficult to close with conventional sutures, and HemiGuard provides a new tool to address this skin type. We have key opinion leaders working in multiple specialties. The key intellectual property is the zonal elasticity. HemiGuard moves like skin. So when there's swelling or when there's range of motion, the HemiGuard is spring-like and can stretch and adapt. And unlike our competitive devices, doesn't cause a blistering effect, as you see here. Our team we're surgeons, so we make devices for surgeons. I mean, we have felt the pain of wound dehiscence personally and with our patients and with our colleagues. So this is what we are addressing. And we're now in over 50 hospitals. Our reorder rate is high. It's over 90%. And surgeons that see this, there's nothing like it. And if they have problems with high-risk patients and they're taking on tough cases, they want to use it. Getting through value analysis is our biggest issue and the most time-consuming effort for us right now. And that is really our goal, is to get some expertise with national contracting so we can start moving product at a larger quantity level through larger organizations, GPOs and so on, and expanding sales and scaling. So thank you for your attention and happy to answer any questions.
Thank you very much, Daniel. Are there any questions for Daniel?
And I'd like to apologize if my image has offended anyone. I never quite know, because we live in the world of wounds, and sometimes that's pretty hard for people to look at. So I apologize if that was a little too graphic for some of you, but this is
Daniel, I can't have my dinner now.
Yes, perhaps. I'm so sorry. I'm gonna order you.
Just kidding.
When you recover, Uli.
Just kidding. All right. Any other questions? If not, we'll move to our next presenter.
Quick question. This is Ben,
Yeah.
one of the Durham residents, actually. So just wanted to get a better sense of how you first found an engineer or sort of design team to help you come up with the initial design. I think that there's obviously a lot of tension lines that need to kind of be played with in terms of how to alleviate the physics along with the tension and how you went about doing that.
Yeah, I mean, finite element analysis really helped us with our design. We worked with Oregon State University in the early iterations of trying to develop this load dispersal. But actually, probably the key breakthrough for me was when I went to the manufacturing facility and I saw how rolling a sequence of rollers laminate adhesive products together. And I realized by successive laminations, you could create progressive elasticity in a dressing. And that's really allows it to mimic skin. And I said, wow, this is going to be easy to manufacture. And I think that's a big pitfall for a lot of innovators is, wow, it's a great idea. Then you get down to engineering it and how are you going to manufacture this at scale and not a ridiculous COGS. So you don't have to pass on these costs. So the idea that we could, really develop zonal elasticity with progressively more stretchy design in a way that's really easy to manufacture, that's already pre-existent in the rolled adhesive industry, that was really kind of the clincher for me. And I wouldn't have thought of it if I hadn't actually gone to the factory and saw how they assemble these laminated dressings. It was really like, wow, it was a great moment.
If I may add something to what Dr. Daniel already answered, There is a huge show called Medical Device Design and Manufacturing, where all kind of companies go there to look for companies that will help you design these products. Obviously, we are one of them, but we have our specialty, which is robotic surgery and remote surgery. But if you go to that show called Medical Device Design and Manufacturing, you'll be able to find somebody to help you for the person who is asking the question.
Great. Good information. Thank you very much. I'm trying to see if there's anything else.
Actually, I had a question for Daniel. As you know, a great deal of the success for a lot of companies like Intuitive Surgical is really related to the success of the robotic surgery. And one of the things that the robots really succeed, excel at is sutures. So have you considered that as part of your design? And are your sutures, they have two different versions, one for the surgeon and one for the robot, or are they the same? And have you done any work in that area?
It's a great question. And I think conceptually it's very valid. However, you come up to regulatory issues. We're a class 1 device because we're a cutaneous external device. That allows us to go in the class 1 category. Anything a robot would be doing would be internal, because as of yet, there's not been any robot-derived skin applications because the skin is external and you don't need a robot because it's easy to access the body's surface. But the concept of tension relief in living tissue is very valid, and it probably could be adapted to robotic applications. At that point, you're at a class 2 device with a much longer development pathway, and you have biocompatibility and absorbability issues. And I think it's a great question, and I think that's the future. This whole, like I used to, we're repairing liver lacerations. The liver capsule is so delicate. And then when it would swell, it'd tear through. Same thing with spleen capsule. If we had something that we could disperse tension on some of these delicate structures, and it could be embodied in a dissolvable, bioabsorbable, then it would be very applicable to robotic or open applications.
So for those who don't know already, one of the things that they discovered with robotic surgery is that the robots have much neater sutures than most surgeons do. And this is one of the areas that they excel at. And these companies who are mostly here in Silicon Valley, and there's about 10 of them. Obviously, Intuitive Surgical is the leading one, but there is 10 of them, and they're all working on how to leverage that success into more operations and more class 3 medical devices, and I'm working with some of them.
Great.
Well, it would be a great discussion to continue later on, because a lot of the lessons learned on managing tension are relevant to the internal body as well.
Yeah.
Maybe we should have a conversation offline, Daniel.
That would be my pleasure.
All right. Thank you very much, Daniel.